Welcome to CE Conversations, a clinical podcast presented by Creative Educational Concepts designed to improve clinician performance and optimize patient outcomes. This session, entitled Interprofessional Insights for Managing Chronic Kidney Disease-Associated Pruritus, Embracing Evolving Data and Emerging Agents to Optimize Outcomes. This activity is accredited for 1 hour of ACCME, ANCC, ACPE credit and supported through an independent educational grant from Genentech. To earn CE credit and complete the evaluation for this activity, please visit the link in our show notes at the conclusion of the podcast. And with that, we'll turn it over to our expert faculty.
So when we talk about pruritus in our chronic kidney disease patients, we look at, what is our basis of our nephrology nursing's knowledge? So what we have to understand about, pruritus and chronic kidney disease is what is the prevalence of it? And if you can think about it in your own practices and the patients that you treat, the physiology of the pruritus, we always automatically think it's, caused by hyperphosphatemia, but what is the mechanism of action? And then taking a look at a patient-centric clinical gravity of managing pruritus in our patients. So how would we define this? So chronic kidney disease-associated pruritus, it's basically, itching directly related to kidney disease without any other condition explaining this symptom. So just for our patient population, it is common. Itching is common in chronic kidney disease. This is common in chronic kidney disease for patients who aren't even on dialysis and patients who are end-stage renal disease who are also itching as well. So it occurs with dry skin in about 50 to 85% of our patients. The clinical presentation is highly variable, and it can be superimposed with certain complications such as impetigo, papulas, ulcerations, or purgo nodulus. So when we take a look at, in our hemodialysis patients, what does the chronic itch look like? How prevalent is it? So our point prevalence is about 25.2% of our patients. At 12 months, about 27.2% of our patients, and lifelong prevalence is about 35% patients. And what happens with this is when you have this type of prevalence, you look at the long-lasting burden and how does it affect quality of life and sleep for our patients. So we see them on hemodialysis in the in-center world, or if you have some patients on home hemodialysis, we don't obviously have the luxury to see them, but in the in-center world, we can see what a burden itching can be while they're just with us 3 to 4 hours. So when you take a look at hemodialysis, and what this is looking at is patients, looking at over the years from 1996 to 2015, and 70% of patients with any degree of itching and 40% of patients with at least moderate pruritus. So as we can see, as we have patients who will vocalize that they have a certain degree of itching, but how do patients share that with us? So when it is definitely underestimated. So patients don't share that with us, and they looked at a cross-sectional survey of asking nephrologists, 204 nephrologists, what they thought the prevalence of itching was or pruritus was, and asking them, is pruritus related to dialysis? And so 32% of nephrologists surveyed out of the 204 said yes, while 67, almost 68% of the nephrologists surveyed said no. So greater than 97% of the dialysis patients were referred to a dermatologist, but only 23% of those patients who went to see a dermatologist were satisfied with their treatment. So when you take a look at patient-reported pruritus symptoms, so when patients will report it, it's near always or always bothered by itchy skin. And who are they reporting this to? And as you can see, what's really interesting is that, 33% of the patients did not report any itching to anyone. That's right in the middle. That's your gray column. While 39% of the patients report it to the nursing staff, the patient care technicians who work the floor, social workers, dietitians, people who are in the dialysis centers. Patients also complained 37% to their primary care doctors. Only 26% of the patients actually told the nephrologist, while 17% of the patients told a dermatologist. So this is looked at about 114 patients. So what does it look like? What is this dry, itchy, rash? What does the appearance look like? So there's scratch marks. If you look to the left, this is on a lower leg with excoriations. And then you have in the middle this nodules on the forearms, which we see quite frequently. It's a hyperkeratotic nodule. And then this is demonstrating on a back and a shoulder, the deep scars of these nodules on the shoulders and the back. And this was presented in KI in 2015. So how does it impact the outcomes? So one would say, okay, they're just itching, right? How does it really, affect you? But when you have patients who are itching 70% of the time, they're also itching off of dialysis as well. So we look at patient outcomes and we want to have good patient outcomes. And the severity is associated with worsening quality of life scores, such as mental and physical scores. It is also associated with poor sleep quality. Patients will report they're depressed. They're depressed because they are itching. People will also associate the depression, decreased quality of life, poor sleep, and are non-dialysis dependent CKD patients. So patients who are not on dialysis. And it is also associated, interesting enough, with 21% higher adjusted mortality risk for patients who have moderate to severe pruritus. This was in the DOPS-2 studies, primarily through the disturbances in healthy sleep. So if you think about these patient outcomes and how it affects our patients. So when you dissect it and look just at sleep, how does it affect sleep? So in some, the sleep problems start right after starting dialysis. So they start to have issues with sleep. So you got to kind of, figure this out, because in your CKD 4s and 5s, especially late 5s who aren't on renal replacement therapy, one of the symptoms of worsening chronic kidney disease is disruptions in sleep because they're not clearing poisons and toxins. And itching of skin is also a symptom of uremia as well. So we see these problems usually begin shortly after starting dialysis, but they can be pre-dialysis as well. And about 28% of our patients had problems with either falling asleep, waking up, their quality, well-being, and daytime functioning capacity. So if you're not getting a good quality of sleep, what's happening to the functionality of yourself during the day? And then itching was intensifies or aligned with sleeping problems. So the worse the itch, the more problem you have with sleeping. So when you take a look at mortality impact, so this is looking at DOPS-1 and DOPS-2, and it's 13% higher mortality in DOPS-1, 21% higher in DOPS-2, and when it was combined, it was 17% increased mortality. It impacts, again, on the right-hand side, the quality of life, and sleep may explain why we're having increased mortality rates with patients who have pruritus. So when you look at the moderate to extreme pruritus adjusted mortality risk compared to patients without pruritus, and again, this was from the DOPS data. So when you take a look at, kidney disease associated pruritus, connecting the symptoms to make a diagnosis. And it's often overlooked by healthcare providers in the dialysis units. So in the dialysis units, 21 to 50% of patients reported severe pruritus. However, only 1% of the medical directors estimated this same prevalence. 17% of patients affected by this pruritus did not report their symptoms. So again, relooking at that data. So moving along, so that is the prevalence. And this is where I showed slides where we looked at outcomes affected because of pruritus, and then the increased mortality risk when patients have decreased quality of life and decreased sleep as well. So what causes this pruritus? So factors associated with it, or if you look on your left-hand side, you have consistently associated with worse pruritus. This is older age, increased CRPs, decreased serum albumin levels, and comorbid conditions such as hepatitis B or C. And then the mixed data is looking at gender. It's looking at our MBD parameters. This is our calcium, our phosphorus, our ALK-Phos, our intact PTH numbers. We're also looking at K2-Revs. How well is the patient being dialyzed? Is the itching because the patient is lacking in dialysis? We look at hemodiafiltration, and also vintage on dialysis is some factors associated with this itching. So if you look at basically the potential pathogenesis of the itching, it is a sensation that comes from the skin and it's transferred through peripheral nerve fibers to the CNS. So as you can see on the right-hand side, we have our CNS. But some of the stimuli, if you look on the left-hand side, is things like parathyroid hormone, histamines, tryptase, or uremic toxins, cytokines, inflammation. So you'll get this dry, scaly skin and these other serological factors. And what it does is it perforates the nerves. So you got this proliferation of the nerves, and it sends a stimulus to the neuropathy of the brain. And this is where we'll see functional and structural neuropathical changes. So inside the spinal cord itself is these endogenous opioid imbalances, which I'll dig into further on. But again, look at patients with end-stage renal disease in the bottom corner on the skin and sensory nerves. So it's that endogenous opioid imbalance, alterations in immunities, this mast cell activation, dialysis-related substances, again, such as parathyroid hormone, aluminum levels, B2 microglobulin, and of course, uremic neuropathy. So how do we approach itching? How do we approach, pruritus in our patient population? So this is just going to be a review of some evidence supported for the rationale for targeting what I talked about before, these opioid receptor pathways in managing our patients with CKD pruritus. So if we look at the endogenous opioid dysregulation theory, so we have the itch, right? As this imbalance worsens and the itching becomes more severe over time, what we see is this imbalance of these opioid receptor expression causing itching. So you're saying to yourself, okay, so we see our patients sitting there itching in the chairs, itching in the dialysis units, and we're saying, what is actually going on? What is this dysregulation theory? So we have itching receptors. They're called CKD-aP receptors, and these suppress the itch. And when they're underexpressed, we see itching, but we also have itching-induced receptors called MU receptors or MOR receptors, and they're overexpressed. So as you can see, there's an imbalance of these opioid receptors, and we're getting the expression is leading to pruritus in our patients. So again, can we balance it? These kappa opioid receptors, the KORs, when they promote pruritus and they upregulate in our patients with CKD. When you have your MU opioid receptors, this alleviates the hyperactivation, which inhibits the itch, and then you get a down regulation in CKD pruritus. So we're trying to figure out a balance, or what we call the homeostasis of our KOR and MORs. It's very crucial for balance. So this endogenous opioid system, you say to yourself, this imbalance of the MU and the kappa receptors in the central nervous system and the periphery, our skin, result in a neuronal sensitization. And that's what the issue is. And when you get the binding of these neurons, it inhibits certain neurons and accentuating a chemical itch, which causes a relief of that itch. This inhibition of the antagonist by MORs induces the itch. So it just causes, how does the itch kick into the spinal cord to allow this opioid imbalance, which causes the itch to the central nervous system? So how do you treat this? This is, we need algorithms, we need protocols, we need guidelines on managing our patients. So when I have patients who are itching, I immediately think of hyperphosphatemia. Are they well dialyzed? So we think about guidelines with kinetics, K2/V. And we also think about MBD guidelines. So are they meeting their calcium, their phosphorus, and their IPTH goals? Are these numbers in range? Are your kinetics in range? And then how do we treat this? There's been a trial of certain emollients for itching in our patients. And then we need to really think out of the box. And luckily there's medications out there now where we consider how we can treat this itch while the patient is on dialysis. So if you look at, this was data as of 2020. So patients itch, I see them scratching, you give them hydrocortisone cream, you give them Benadryl cream. This is baseline therapy. This is what we used to do. Patients who have worsening itch, we send them to dermatology. They use this phototherapy, which is, could be a possible severe side effect, such as skin cancer risk. We give them oral antihistamines. We give them systemic steroids, but, they work for a little bit, but generally they're not effective. They're widely used. They're cheap. However, some of the adverse side effects of these are sedation and infection as well. So then there was a use of gabapentin or pregabalin, and we did see 85% of relief while we're using these agents. However, some of the side effects are dizziness, dry mouth, and somnolence or confusion, especially when they're dosed in our CKD-ESRD patients. So when we take a look at, what is the data before the newest medication out there, what we call pre-difelikefalins is that these topical therapies, the emollients, we have to have the patients apply them 2 to 3 times a day. Well, what is the reality of that happening? It's really not sustainable for long-term treatment. The phototherapy, it's usually 3 times a week. That is hard to get into with our patients who are already coming to dialysis 3 times a week. Sometimes it's not covered by insurance. It's been challenging. And then again, systemic therapies such as the gabapentin, the mirazepam, the serotolin, different type of medications we use for systemic therapy. So again, looking at the current treatments for managing CKD pruritus, most clinical trials have had a very small sample size and they're poorly designed. And the currently used treatments can have serious side effects and not great efficacy or sustainability outcomes. And so to date, there's only one FDA approved medication to treat this pruritus. It's called difelikefalin. And it was approved in the United States in 2021 in August for the treatment to moderate to severe pruritus associated with chronic kidney disease in adults who are currently on hemodialysis. So what is the issue with our current therapy? Well, there's been a lack of efficacy, maybe because treatments don't necessarily target the itch mechanism. So why aren't the emollients or the gabapentins or the antihistamines or the steroids working? Itching is very multifactorial. The pathophysiology may be different and is different for each patient. So again, we need to do a patient-centric care here by individualizing the treatments for our patients. And again, not enough is known about itching in our CKD patients and the pathophysiology. So from a clinical perspective, patients find antihistamine and gabapentin to be oversedating. I do have patients tell me that they feel like zombies. They feel like that the next day, especially with these antihistamines. The UV light therapy is too difficult and time consuming, as we talked about it. Patients will continue to itch despite these interventions. And then we look at the outcomes. How is this itching affecting our patients, their quality of life, their mood, their sleep, clinical outcomes, and their mortality and infection rates? So antihistamines, let's get to our first line of defense that we currently, we're using is antihistamine, widely used. These antihistamines are Benadryl, which is diphenhydramine. It is hydroxyzine, which is also called Atarax, Loratadine, Claritin, or Zyrtec, or they have these mast cell stabilizers as well. Studies will reveal that efficacy are generally negative, and the side effects are the oversedation and especially constipation in our older adults. Gabapentin, when we use things like gabapentin or pregabalin, what are the side effects? Are dizziness, drowsiness, confusion, dry mouth, visual changes, angioedema. There is a high incident rate of altered mental status, falls, and fractures. And in our patient population, the max dose of gabapentin should be 300 milligrams once a day. We start low and slow in our patients, usually 100, and then we taper it to TID, or we just give it in the evening because of these side effects, such as the drowsiness, the somnolence, and risk of falls. So these, when we take a look at the opioid receptors and antagonists, pain and itching pathways, Those MORs, or those mu opioid receptor antagonists, are naloxone and normoxicilline. The peripheral capillary opioid receptors, there's one called nalforin, and it's approved in Japan. But here in the United States, again, we have the difelikefalin, and it's been approved in the United States for patients on dialysis, hemodialysis, to be given on hemodialysis. So the mechanism of action for this medication is it's a peripheral restricted. So it's selective on the KOR antagonist. So that is where the antipruritic effects via the activation of the KORs. Again, remember, the KOR and the MORs are your opioids in the spinal cord. And this affects the peripheral sensory neurons along with the immune cells. So the activation of these KORs expressed by the immune system results in a reduced release of pro-inflammatory mediators, certain cytokines. And when you activate, again, the KORs on the peripheral nerve tumulus, it results in inhibition of ions channels responsibly for afferent nerve activity, as you can see demonstrated here. So this is the mechanism of action. It's quite detailed. I get it. So what did the studies show? So these studies were obviously hyper-focused, they were focused on chronic pruritus in our hemodialysis patients. So the patient selection, there was 174 patients. To qualify for this study, you had to be over the age of 18, be on dialysis thrice weekly for greater than 90 days, have moderate to severe pruritus as using the tool, and they were followed for 8 weeks. So we had patients who were given placebo, and then we had doses of 0.5, 1.0, and 1.5. So what were the primary endpoints that they hoped to get from this study? So the primary endpoint was weekly mean of daily WI-NRS scores, which I'll get into. Secondary endpoints were skin index 10, quality of life, and other endpoints were quality of life, the sleep, the itching severity, and the impression of change. So the conclusion was they found it was very effective at reducing the severity of pruritus on hemodialysis patients. With the chronic moderate to severe pruritus, they saw improvements in sleep, social functioning, and moods. Adverse events are diarrhea, dizziness, and vomiting for these patients, and there was no reported physical dependence for these patients in this study. So improvement in itch-related quality of life measures and sleep disturbances. So they did a skin dex 10 score, a 5D scale score, and an MOS sleep disturbance score. And as you can see with the doses, we saw improvement in changes from baseline in each of these assessment tools from placebo based on the dosing of the medication. So this has exhibited statistically significant improvement across all quality of life domains in these patients. So again, this is just digging deeper in and looking into scores based with medicine versus placebo, with the itch score, the skin dex 10 score, mean change in worst itching intensity. As you can see, we saw a better effect than placebo if you looked to the right by week 12. So when they looked at the CALM-1 trial, what were the adverse events of this trial? It was a 12-week double-blinded intervention period. And as you can see, the most frequent adverse events were diarrhea, dizziness, vomiting, and some sinusitis. There was then at 2-week discontinuation of period, we with looking at the adverse, the most frequent were some abdominal pain, a fall, diarrhea. As you can see, very little side effects compared to the placebo, interesting enough. Well, like if you, so when you looked at the CALM-2 study, which was a global study in hemodialysis patients, again, suffering from moderate to severe pruritus, we saw rapid sustained itch reduction. It was very well tolerated. and safety was similar to prior studies in the CALM-2 study. So when you take a look at an analysis of CALM-1 and CALM-2, we can see across the board, we saw reductions in the WI-NRS score over 12 weeks, a 3-point, a 4-point, and anywhere between a 3 and a 4-point in the weekly mean in these patients compared to placebo. So I'm going to skip over those 3 slides. So I want to get into, since I've got about 30 minutes left here, I really want to get into the nitty-gritty of how, as nephrology nurses, how can we manage these patients? How can we provide them better quality of life by reducing this pruritus? So looking at some very practical principles of our patient-centric, patient-focused care in our hospital setting and or dialysis clinic setting. So this is looking at we're going to go to a case study. And so AT is a 67-year-old female with a past medical history of type 2 diabetes and chronic kidney disease. Her diabetes is well controlled with medication and lifestyle management, but AT was initiated on hemodialysis 6 months ago. At each of her appointments over the past 2 weeks, you have noticed red streaking on her arms and hands. She initially told you she thought she had poison ivy from a recent family trip, but at yesterday's appointment, she expressed concern that there might be some other cause. She says the itching is getting worse and she is getting worried. So what other questions would you need to ask AT before proceeding? So again, thinking about how to stimulate conversation with AT to kind of deduct all of what the cause of this pruritus could potentially be. So some of the questions could be, first of all, understanding how long she's been diagnosed with chronic kidney disease. Some people are diagnosed and rapidly progress to CKD stage 5. Some people can sit in stage 4, stage 5 for years and years and years. So understanding what her vintage to chronic kidney disease is and renal replacement therapy. How and when did this itching start? And do you feel like it's been getting worse over time, or even with as you age, does it get worse? Is it worse at night or certain times of the day? Is it generalized pruritus, like all over your body, or is it localized? And if it's localized, see if they can tell you or show you where the itch is. Any characteristics of it, and anything that exacerbates it or relieves it or triggers it. So asking these poignant questions is important to be able to manage these patients and properly treat them. Of course, look at their medications. You need to get a detailed drug history. I always ask patients, are you using a new soap? Are you using a new medication, new foods, or have you introduced something new? This is always a simple question. What have you tried? What are the treatments that you've tried? Things that have been, whether prescribed by your primary or dermatologist. Are you seeking something over the counter? Was it topical? Did you take a pill? Looking at that. Do an assessment of the skin. Take a look at the skin. Take a look at AT's skin. Look for signs of infection, any type of inflammation, infestation, a rash or discolorization, or, what is the color of this rash? Different things like that. And ask them how it's affecting their lifestyle. How is this affecting your mood? How is it affecting your life? Are you able to function with this itching? Again, looking at the quality of life factors, such as, are you still enjoying the same activities? Or is it disrupting your life, the patterns of your life, or your socialization because of the itch? Is it affecting your sleep? Are you getting as good of sleep quality that you used to have before the pruritus kicked in? Are you tired all the time? And then is it impacting any type of personal relationships as well? So after further discussion, you learn that AT's itching has become nearly constant over the last week. And only oral diphenhydramine, which is Benadryl, has offered any relief at all. Unfortunately, it makes her so drowsy she can only take it at night. Very common in our patients. I tell patients, don't take Benadryl and start driving a car, different things like that, because, it does really make people drowsy. And even at a 25 milligram PO dose, it can, especially in our patients who have chronic kidney disease. So she also indicated that her quality of life is moderately impacted overall, but her sleep quality has suffered greatly. So if your sleep quality is suffering greatly, you're going to see an impact on your quality of life. She vocalizes that the Benadryl or the diphenhydramine does help her go to sleep. However, she usually wakes up in 3 or 4 hours because she's itching. So the itch wakes her up, excuse me, and she really can't get back to sleep. Our AT cannot get back to sleep. So the fatigue is making AT have trouble focusing at work. She's had to miss several of her granddaughter's evening ballet recitals. So that's indicating quality of life. If she cannot be focused at work and she's missing things that she really enjoys to do, this is quality of life. So what you suspect is that she has, chronic kidney disease associated pruritus. So what will be the screening tools that you should consider using to help establish this diagnosis? So if you look at the screening tools here, there are several. So there's ones that you can look at for the intensity of the itch, such as a visual analog scale, a numeric rating scale, which is NRS, a verbal rating scale, an itching severity scale, ISS, a pruritus grading system, PGS, or a 12-item severity scale. When you take a look at the course of the pruritus, you can look at itch-free days, again, that 5D itch scale, which they looked at in the CALM studies, looking at an CKD-aP, patient benefit index or a standard. When you look at quality of life, there is a tool called an itchy quality of life, looking at how it affects quality of life. There's a dermatological life quality index. And of course, the KDQOL-36, which we see in our patients over across the spectrum of our disease state. And the treatment goals, they look at the patient benefit index of the standard and the patient benefit index of pruritus. So these are some screening and assessment tools that can be utilized. So when you take a look at this for our patients with pruritus, we want to rule out any other cause of pruritus. So that is really sitting down, having conversation with your patient, understanding other morbid conditions, understanding other medications that they're on or maybe been started on, really doing a deep dive into their case. You want to ensure for sure, first of all, is the patient adequately being dialyzed? So, when you're doing your rounding, you're talking with the nurses, the patient care technicians, the doctors, the nurse practitioners, the RD, the social workers, are patients, getting good dialysis? Are they coming to treatments? Are they staying on their full time? Is there adequate clearance? Is there, what is anything going on with their access where they're not getting adequate clearance? Looking at things like that. What are their dialysate flow rates? What are their blood flow rates? Looking at the whole reason why they might not be adequately dialyzed. And then you want to consider some allergens, looking at if they, a heparin-free trial. So don't give them any heparin at bolus or hourly, if that's how your unit uses, or, a mid-treatment dose. Think about things like citrate locks or citrate flushes. If you're going heparin-free, you can use normal saline flushes, and these can be adjusted with treatment goals as needed to include the volume. So if you have a patient who is not getting heparin, you want to rinse their system about once an hour, if not once every half an hour. And if you're rinsing that with 50 to 100 cc's of saline, you want to make sure you add that into their volume removed. So what type of dialyzer are they on? Should we consider changing their dialyzer, their tubing, and their dialysate? And any latex allergies, of course, as well. So considering these other allergens. So when you look at these post-screening assessments, you can confer with other members of the interdisciplinary team and confirm that you are providing a diagnosis of chronic kidney disease associated pruritus for AT. So when we take a look at, what medications would you potentially consider for AT? And again, these are, these can be very subjective. Some people, depending on the way you practice, the way the physicians and the nurse practitioners and the PAs that you work with practice, you can provide an antihistamine like hydroxyzine, which is Atarax, 25 milligrams by mouth 3 times a day. That would be a bit tricky because I find with my patients who are on Atarax, they do get sleepy. I usually never give Atarax 3 times a day. It's maybe once a day in the evening. It's usually what I find Atarax is less drowsy than Benadryl, but again, it still creates some drowsiness, and that could be, cause some problems in our patients, like increased falls, increased confusion. We use a lot of topical emollients twice daily to the affected areas. That's another option. Gabapentin 300 milligrams by mouth 3 times a day. No one should ever consider this. This is too high of a dose for our dialysis patients because of their clearances. This will knock them on their, just make them feel awful, confusion, very, very scary safety issues with giving this much gabapentin. Or you can give the difelikefalin 0.5 milligrams per kilogram IV bolus at the conclusion of each dialysis treatment. So I don't know how well people are versed in the medications, but obviously my go-to would be D for this patient. So if we start them on it, how do you give this? How do you give it? It needs to be delivered via IV bolus into the venous line of the dialysis circuit at the end of the hemodialysis treatment. So again, you don't want to give it the last 5 minutes of dialysis. You want to make sure that the patient is rinsed back, and you give it in the venous line of the dialysis circuit at the end of each treatment. So again, understanding the timing. If you have new nurses or float nurses who are not familiar with how to give this medication, making sure they're well versed on how to give the medication. Symptom improvement is swift and robust. So within a week, you look at AT's mood and energy, and you see it's increased. The red streaking on her arms and her hands is now nearly gone. So in addition to therapy, what other non-pharmacological options can you suggest for AT to help control any residual CKD pruritus symptoms? So how do you manage symptoms? This is really important, especially with our patients, and especially if they have itching on their access arm, because I've seen people have itching so bad that they itch and they get their access infected. So bathing. So using fragrance-free soaps. Let's just go land of no fragrances. But you need to avoid excessive bathing as well, because that can just cause dry, irritating skin, and avoid excessive heat. Obviously, with the bathing, you're going to be conscientious of what type of access the patient has as well. So avoid any clothing that may exacerbate this itch, such as wool, or if there's certain clothing that the patient can identify. And what do you wash your clothes in? You should try to wash your clothes in a fragrance-free laundry detergent. Maintain nail hygiene. If your nails and they're dirt and nasty under the nails, make sure the patients trim and clean their nails frequently, because that can create infection as well. Avoid frequent rubbing or scratching. Try to keep the house cool, and see if you can get some humidified air in there if needed, because heat can be very drying. So this is the time of the year I see my patients itch more frequently, to be honest with you, just because they've turned their furnaces on, the air is drier. Many of them don't have dehumidifiers in their homes. So again, understanding the seasons of the year, which potentially can cause increased itching as well. You can add topical emollients, of course, and some people consider acupuncture as well. So when you take a look at how does the interdisciplinary team manage, this pruritus in these patients, we need to understand that we need to collaborate with each other. So if you remember earlier slides that looked at how patients reported itching, remember patients report itching mostly to nephrology, to nurses, but it's basically nursing staff, the people in the in-center dialysis units. They're going to report the itching to them over reporting it to the nephrologist. So it's our job to report this to the nephrologist when the nephrologist rounds, or the PA or the APP rounds, for sure. Or patients will tell you that they went to a dermatologist or their primary and they're reporting itching. Well, if that's the case, please, transcend that information to the nephrology team as well. So we want to work together, collaborate, and develop a plan of care for this patient that considers the goals of therapy, right? And how they're related to the patient's health outcomes. As we know, we see increased mortality in these patients and quality of life. understanding their health literacy, having a capture of what patients really understand about their health and their literacy levels, understanding the prognosis and the disease course, and be able to communicate that with your team and of course with the patient, but having them realize this is your prognosis and this is where we're expecting the disease course to go. Understanding what the treatment plans are, the medication regimen is, and the outcomes measured. Identification of any emotional or behavioral needs. Also, a need to refer for supportive care, such as support groups or behavioral therapy, or just talking with other patients, in the dialysis unit themselves that have suffered from this pruritus as well. I find that patients, when they're sitting in the lobby waiting to come in for dialysis, to have loads of conversations out there. So it also could be like topic of the week or topic of the month if you have any type of education in the lobby, and the social worker, the RD, the nurses can take this on where we discuss itching in itself.
Thank you for attending this edition of CE Conversations. We hope it's been impactful for your clinical practice and most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.